discuss some 7 things where people they talk about corona plus you.
You put the worry. You don't know say corona really kill black people.
Make you no make anybody lie you. Corona no dislike give anybody crap. True say it start for China, but right there, it catch everywhere. Where they fix anybody, especially people where they get some other sickness. For places like Yankee, corona they kill black people pass. Yeah, Charlie. Some people say they talk say China people with share do am, or it be 5G self where they cause them. But shine your eye, it no be anybody do am. Where 5G to no go fit cause the sickness. The 5G self, it dey like the 4G where we all they take browse ready. It just be upgrade. People too they talk say if you get corona with chop plain, take garlic, onion, ginger and lime, the sickness go. But this one too be lie. This thing's good for the body, mom, but I don't know if it prevent or cure corona.
So what about Sobolo?
Me self, I dey like Sobolo, but into no they do corona nothing.
Appeal to
corona mainly they attack the lungs, so appeal no go fit do am nothing. The truth be say, people wey dem dey booze, corona they feel worried them papa. People too they talk say if you cut onions put your room, corona no go come there. But corona no they like mosquito, where go fit kill am plus coil.
Then how we go feel protect on our body?
Corona they spread where more people self get, where they no know. So Charlie, if you no get anywhere important go, make you day house. But if you really for come out, then you for wear mask, then stay at least 2 meters away from other people. If they wash your hands, then use hand sanitizer more times. But I beg, make you no drink them. If you dey call for sneeze too, do for your elbow inside. Take some bleach to clean surfaces where they touch. But this no be for your body. Finally, if you feel say get corona, make you go chop for one corner, so say no go spread them. If you get plenty rest, then drink more fluids. But if you dey make worse, then for call the emergency numbers. Charlie, this be all for today. But if I hear any other thing, I will come back to talk about them. For now, if we make sure say we go protect we, one our family, one our friends, then everybody from corona. We all for play one apart, so say we no go increase the pressure where it dey on a healthcare system and on a healthcare professionals them at all. But we for take responsibility and keep fighting with positivity.
All right. Hello, everyone. Welcome to our viewers. Welcome to today's episode of the HealthInfoAfrica Show. This is your weekly source of critical health information, news, and education. So for us, every week, we try our very best to bring you in-depth discussions that will help or enable you to find, understand, and utilize health information. My name is Angela, and I'm co-hosting the show today with my 2 gentlemen. Hello, Daniel and Edward.
Hi, Angela.
Hello, fine gentlemen. How are you guys doing?
We're doing well. How are you doing, Angie?
Doing very well. So good to have everybody back, given the crazy weather we've had here this past week. So good to see you guys. I hope we are all staying safe, and we'll be here many more times. So for today, for our first segment, regular host guests are not able to join us. They may join us late in the show, but we'll turn our attention to mental health and talk about how it's being impacted by the COVID-19 pandemic. So with us today, we have Thelma Alaubela, who is a clinical pharmacist with many years of experience under her belt. And she's also a lecturer at the University of Health and Allied Sciences in Hohoi, Ghana. Welcome, Thelma. Good to see you. It's been ages.
Yes, thank you, Angie. It's actually in Ho. We have another campus at Hohoi anyway. Okay. So you are right. Thank you, Angie.
Thank you very much. Thanks for joining us. I know this was on short notice and we had to shift things around a little, just like the weather. So thank you for accommodating our last minute changes. Edward, do you have anything to say before we get started?
I mean, I'd like to also say that we really appreciate her for, joining our show today and talking about a very important topic, which is something related to mental health. We all know that without mental health, our physical health doesn't mean anything, right? So I'm very pleased to have Thelma join us today.
Okay, thank you so much, Edward. So Thelma, just remind our viewers, give us a little history of who you are. I know who you are, but just reorient our audience, let them know who you are. You can sell yourself best, so take it away.
Okay, thank you, Angie. I'll first start by saying I am a teacher practitioner. I'm a pharmacist. I finished in 2007. Was inducted in 2009. finished from KNUST. I worked with Ghana Health Service for 8 years, so from 2010 to 2018. And then I joined the university in 2018, and I'm still with the university. I used to teach whilst I was in the hospital. Whenever we had interns, I just want to impart knowledge. So I guess that is what brought me this far to the university. The School of Pharmacy at the University of Health and Allied Sciences has 6 departments, and I happen to be with the pharmacy practice department. So we actually gel all the pure basic sciences. The 5 other departments, it's more like pure sciences, but for the practice, we are more of the applied science. Mm-hmm. I have interest in endocrine and psychiatric pharmacy. So that's why I'm here to talk about the mental health and COVID.
Thank you so much, Thelma. Thank you for that wonderful background. I've known you for years. We may not talk every day, but I do know the work you do and some of the things you stand for. So we really appreciate your time for being here. So if we are ready, let's just dive straight into the conversation. So I think we all have an idea of what mental health is. It's undeniably a really broad topic. But can you share with us and also our audience what are some of the objective and subjective things that someone might give you a hint of that will indicate what their mental status is?
Okay, so I heard Edward initially talking about health in general. So there can't be health without mental health. We know, I think since 1946, thereabouts, WHO came out with a definition for health. Being not just the state of physical and then what mental health. That health is a complete state of physical and mental health and not merely the absence of infirmity or disease. So it means that mental health is an integral part of our health. The textbooks have all sorts of definition for mental health. So we say that it is, it's a proper brain functioning, that helps you to carry out productive activities. And then you tend to have fulfilling relationships and you're able to adapt to change and adversity. Okay. And I dare say that change is the one thing that constantly affects mental health. Example is what we are facing with now. The whole world it's literally on its knees. We are trying to find a way around COVID. That's a huge change. Nobody envisaged COVID would make us this way. That's a change we are all grappling with. So definitely it will have an effect on the mental health. And change, we know it's the only constant thing. There will always be change. So mental health, for me, should be everybody's business. Right. If you are physically well, but mentally you are not completely healthy. So for me, it's a basis for everything we do.
Right. Okay, so Thelma, let me just follow up on that. So what are some of the cues an individual might give you to tell you that they are not in their right mind, quote unquote? Because someone can be all dressed up in a suit and tie, but they are not functioning properly, or they have issues with anxiety and stuff like that.
So that's true. So if we all remember Macbeth, Shakespeare said, well, there's no art to find the mind's construction on the face. For me, that clearly defines what mental health that you cannot objectively see. So for instance, if I had come to the show in my nightgown, that is, for me, functioning properly, that's inappropriate. Or Angie, if you had come in undergarments, or Edward, you had come in undergarments, we'll begin to question if everything is all right with you. But in the confines of your room, you can wear your gown, your underwear, you can wear your nightgown, you can wear your PJs, and there will be no problem. But when you don't know where to take your PJs to, when you are not able to draw the line, then you have to be taken in for assessment. Okay, it's not a straight jacket thing to see somebody and say this person has it. Okay, we do have acute episodes. For instance, I mean, somebody just begins to talk all of a sudden, screams on top of their voices. It's also the person is having an episode of a mental ill health. So that is clear for you to see. But the subjective ones, for instance, I say I hear voices. I think I'm the president of the United States. We call it delusions. Okay. Those ones are subjective. So you need to assess the person. We have assessment tools that we use, but we complement that with assessing the patient before you. We don't use the tools only. We marry the tools with basic clinical assessment so that you can come out and say, okay, you have this mental, health disorder. Okay. There's actually a manual that is used. It's called DSM-5. It's Diagnostic and Statistical Manual. The 5th edition is the most recent, DSM-5. So it helps to diagnose what individuals. But you don't use just the manual. You use the manual and the patient before you to make a conclusive diagnosis.
Right.
All right. I'd like to add something real quick. So you just brought in a very interesting thing, which is the DSM-5, which is a book, right? And I happen to have one of those books in my office, and the book is really big, right?
It's huge. It's huge.
When I started combing through that book,
voluminous.
Yes.
Voluminous.
When I started combing through the book, I said, this book is even bigger than all the other diseases, which tells you, that mental health is really huge, right? And again, when I went a little bit deeper into it, I realized I could probably be sick too, or a lot of people that I knew before could be sick. So the question becomes, how do we, streamline the way we diagnose people? I know we are not a psychiatrist or anything like that, but are we including everything and anything, such that if you look through that book, you can obviously kind of find something wrong with you? And also, amongst Ghanaians, right, this is something, whenever you mention mental health, maybe we should go back and use something that you said mental well-being or something like that. As soon as you mention mental health, everybody thinks, Abodam, and how has the definition by WHO over these years, how has it been able to shape how we think about these things, especially in Africa and even in Black people in the United States? Unfortunately, we tend to think that the person is always crazy.
Yes. So thank you. I think I'll start from where you asked about using the DSM-5. So it was designed by the American Psychiatry Association. It's actually more around North America. Okay. It's supposed to help with the diagnosis of mental ill health. Okay. And like I said initially, it's a guide. Okay. You can look through it and probably say, okay, I think could be wrong. One other aspect of it, there's anxiety in Ghana here might be seen differently as anxiety in the US or in Latin America or in Europe. Okay, so you need to put all these dimensions together before you can diagnose somebody. The DSM is supposed to be a basis, okay? It's supposed to be the foundation, but the blocks or the block work that you carry out will be based on the patient before you. And then we call something cultural idioms of distress. The cultural setting has what they put quote unquote as distresses. Okay, that is one. And then to answer your question of, I choose to call it stigma. So mental health has a stigma. From the days of asylum, okay, if you watch, Accra Psych used to be called what? Asylum, okay? The name was changed to what? Accra Psychiatry Hospital. So we used to see mentally ill individuals as violent, as a threat. So there is this notion, misconception, misrepresentation that we need to work to change. There's actually something that we call, we have stigma reduction strategies. So we sometimes use contact persons. So individuals who have mental ill health, they are more like ambassadors. So that we kind of make them, they would have been the show-based people for anybody else who has that kind of condition. So they don't remain in their shells. They come out. Because I know for you guys in US, if you check, you see that there are people who have bipolar, but they are doing so well in their fields. Okay, we have a lot of scientists who had mental ill health, but they were able to invent a lot of science-based, should I say, instruments or machines that is making work easy for us now. So for me, I think the strategies to reduce stigma, we should throw more light on it. And people who matter within communities and societies should be actively involved. Opinion leaders, chiefs, the administration of the day, the presidency should be involved. It's unfortunate that maybe it's not as active as we want it to be, but they've achieved some strides. There used not to be a mental health authority. Now we have a mental health authority. So that is a start. And for me, everybody should be a mental health advocate. You don't have to diagnose somebody with a condition. You don't have to necessarily treat, but you can be an advocate. And let me tell you why. It cuts across every sphere of life. So if we talk about gender-based violence, it's a mental health issue. Okay? So it means if you're a woman in a certain part of the world, you'll be mentally affected because you are prone to being attacked.
Right.
When we talk about childhood, mental health disorders like autism, selective mutism, or
ADHD.
We call it separation ADHD, separation anxiety disorder. All these are mental health disorders. How do the mothers feel when they have children with these kind of mental health disorders? Do they feel welcome within the community? So for me, all of us, nobody should be out. All of us should advocate for what? Mental health. I don't know if I've answered all your questions or there's still one. Edward.
I think we've touched on a lot of the most important things, right? And I think I'll let Angie go.
Thank you so much, Thelma. That was very thorough, and I'm sure we've all learned a lot from what you just took us through. And I wanted to touch a little bit on the pajama issue. Some of us have had to wear pajama bottoms to I just wanted to put that out there. So I know right now this COVID-19 pandemic is one of the commonest causes of anxiety for a lot of us, myself included. But given your background in mental health work, what are some of the causes or what are some of the triggers of anxiety? And is there any link with family history, or is there a genetic component to people who have anxiety or other mental health issues?
Okay, so I'll start off with the COVID. Like I said from the beginning, we've had SARS-CoV with us, but on this scale, now it's SARS-CoV-2 we are looking at. We are still trying to grasp what the whole SARS-CoV-2 is, COVID-19. So there's a lot of uncertainties. And we say anxiety, we loosely define anxiety as it's future oriented anticipation that something will go wrong. Okay, just that you want to see how you cope with it when the negatives actually happen. So, like I said, we don't know much about COVID yet. Even the vaccine, at best, it will protect you for a year. What happens afterwards? You go for another jab. So these are the uncertainties that will make people anxious. People have lost breadwinners. People have lost spouses. People have lost children. So a whole family has been infected with COVID, and they had to be put in separate rooms. They don't get to see each other. Partners don't get to see each other. Children don't get to see parents. That in itself is putting them in a state of anxiety. So for me, there's a direct. And the issue of conspiracy theories around this vaccine, it's just heightening their anxiety. People are saying all sorts of things about the vaccine. It's evil. It's a ploy by whosoever it may be to target Africa. I mean, the theories are endless. If you hear them, in the normal frame of things, in the normal scheme of things, it will get you to rethink, and it will get you to be scared, and then you'll be anxious. Fear gives birth to anxiety. Okay. Then the issue of it being familial or genetic. Yes, there have been studies that have been done. They actually use monozygote and dizygote twins to find out if. So there's one thing that can trigger anxiety. One of it is personality. That personality is AS. They said the AS is not the sickling AS, but they say anxiety. The S I've forgotten, but what it does is it predisposes you to have a heightened sense of anxiety. Hence, you are predisposed to what? Anxiety disorders. So they've linked some genes, chromosomal genes, to people presenting with anxiety disorders. So there's a link. There were studies in 2017 and 2015, and way back in 1998 that were done to link genes or genetics to anxiety. So there is a familial link.
All right. Thank you so much, Selma. Edward, did you have anything to add before we take a break?
I had about two things to add. So the first one is anxiety the same as too much fear? Because my good brother and Kwame and I, we're scared of snakes. Is that something that we can say that we're anxious about snake? Or
that makes few of us. That makes few of us. I am afraid of anything crawling. Anything crawling. Apart from a baby crawling. Anything else crawling. Gives me the creeps.
Any crawling creature, right?
Okay, like I was saying about anxiety. Yeah. So, like I was saying, that fear gives birth to anxiety. So there must be, fear is imminent. So let me try to just simply link it this way. Fear is proactive reaction. Reactive. Fear is reactive. So I see a rattlesnake right now. There are two things. Your response is to flight or to fight. So either I run off or I get something to kill it. That is fear. Okay. And that fear is what we categorize under what? Phobias. Okay. Then we have the proactive one. So fear can actually give birth to anxiety. Like I said, the anxiety is a future-oriented what? Anticipation. You are waiting. You know it can happen. So, and it's a negative thing. So what do I do? Okay. So they are filled with a lot of, obsessions. Right. So under one of the type of anxiety, we have obsessive compulsive disorder. So let me use myself as an example. I went for a COVID test because I had been exposed to somebody, in fact, two people who had tested positive for COVID. And the results was going to come in 24 hours. So, and it was going to be via email. So when I came home, a lot of things were going through my mind. Not that I don't think I can be positive, but what I would do, I was thinking ahead of my results. Okay. So if I was positive, what will I do? I was obsessed with a lot of thoughts. Okay. Then the behavior came in. I started putting things in place. I quickly cooked a lot to put in the fridge. My family is in Accra and I'm in Go. So I planned it out. If I come out positive, they are not coming to visit me. I'm not going to visit them till I'm through with whatever management that I'll be put on. When I test negative, then I can go to them, you know. So that was anxiety. That is typical of anxiety. Fear, you see it and then you react, okay? So as for the phobias, we have a lot. People have fear of animals. So we have nature, we have animal, we have environment. So nature, I'm afraid of heights. I've climbed a Fajoto anyway, but I didn't look down. When I got up, I refused to look down because I might fall off. Okay, I'm afraid of heights. So that is more like nature. What about animals? Snakes. Some people are afraid of spiders or crustaceans. Anything that crawls on the wall, they cannot stand. They might even pass out. Others who are afraid of blood and injectables. When they see blood now, or even the thought of going to theater, they can pass out. Okay, that is a phobia. The phobia is kind of different from the anxiety. Okay, because the fear would give birth to the anxiety.
Yeah. Right.
So does it mean that if I constantly, see snakes all the time, can I develop anxiety out of it?
Well, it's not straight jacket. And what you can actually do is when you frequently see snakes, with time, what that can do is actually help you overcome that phobia. We call something cognitive behavioral therapy, CPD. So one of it is to expose the person. Get the right exposure over time. Then you realize that you overcome your fear. So you can actually try it, CBT. It can actually work for you. Maybe once in a while you go to the zoo or anywhere that has reptiles. You see them, maybe you start with once a month, you go and then it becomes bi-weekly. Then over time, you realize that it's not such a big deal.
Right. So this is just by the way, you mean the phobia, this is not Accra House of Folks, right?
No.
I'm just joking. Yeah, but it's the same as fear. Okay, great.
Yeah, I think we'll get you a 1-year pass to the Chicago Zoo so you can go pet some snakes.
All right, sure, I'll do that. Yeah, I think I'll bring my friend Kwame with me. He's very into mouse and he likes mouse. Yeah.
All right, guys. Thank you so much for staying with us. We'll take a quick break. Relax. We'll be right back.
All right. Okay.
It is the senior most community pharmacist, Dr. Tuli.
Tompo Asembeng.
Oh, no lie. Then I say if your driver can't pick you, I make you people give me lift go. Shark is inside now. I'm at to say it's on link copy. But
Tompo, 11 p.m.
Oh, if it comes in for see the neighborhood, give me. I guess some entanglement before that side.
You know they hear social distancing, eh?
To lepe from D, some crowd, the whole. As I be young in the Amas are they cool. If you no go pick me to catch him in small left.
See, this be the problem. Who tell you say corona affects youngins? If you know they care about your life, if a guy say NSL be over 50 years, away get hypertension, way poppy to be diabetic. Charlie them their cold mess them up.
You are go wear face shield.
And that changes anything? That thing they protect only your eyes.
Plus face mask.
Charlie, the youth will they take this thing for granted. It may not kill you, but if it give you long-term damage to vital organs like your lungs, if you go get for outside cargo house, they give your OGs where them die. Will you be able to fend for yourself?
Chama, so I can't say because unless I start, they do Yahoo, enter Benino, na funeral cost me this the COVID said make it left one at talk.
If people know they follow simple directions like social distancing, hand washing, When face mask and things, the COVID no go anywhere. And the way that you they make careless there, it be like you no go left with anytime soon.
So to lazy my shadow make beans in.
If you love yourself and the people around you, they house and take your shadow go do go back cry.
You are here, you more like a dog me. So they kill my vibe cry. Make a go play my FIFA.
And keep fighting with positivity.
Thank you so much. I always love to see that commercial, and may the soul of Professor Obri Dako rest in peace. So I'm glad I hope everyone is enjoying the discussion. We wanted to make it really light, giving all the events and the issues going on in the world. So I'll bring my co-host back in, Edward, and our guest, Dalma, to continue the discussion. I'm really enjoying this. Yeah.
Thank you.
All right, Ed, take it away.
All right. So yeah, I mean, talking about anxiety and also even mostly depression as well. Are these two related? And which one do we commonly see amongst like Ghanaians?
Wow. Okay. So, like I said about anxiety, is a future thought of something negative to happen. So your brain is just wrapping itself around. So anxiety actually is a form of brain mechanism to protect you from harm. Okay. It's just that the brain has its functions that at the end of the day become more of harm to you than initially it thought it could be of help. For depression, we have what we call clinical depression. I think we have all been through some form of depression or the other. So, for instance, you were anticipating something good to happen, and it didn't happen. So you were anxious for something good to happen. It didn't happen. Rather, it was something negative. Then your mood changes. Okay, we call that mood change depression. The depression too is not a standalone. For instance, if we take a condition like bipolar, bi meaning two, you are swinging between two poles. Okay, one time you are manic, another time you are depressed. So when you are manic, you are overly excited. Okay, and then when you are depressed, you are so down. The worry with depression is that if it becomes clinical, it continues for about 14 days and is untreated, it predisposes you to one dying by suicide or some form of other harm to yourself. Okay, so we should be able to diagnose depression. Clinicians can diagnose depression even at the primary healthcare level, and then refer upwards to a psychiatrist. For me, the two are linked. Okay, but as to how to differentiate when or what has what. Okay, but for the earliest sign, if someone's mood is down, okay, for a very long time, even for a week, okay, I think the person should seek help. Because I said clinical depression, we are looking at 14 days continuous. Okay, it's possible the person has bipolar or some other mental ill health that is yet to be diagnosed. So studies have actually shown that if we catch this depression early, especially among teenagers, we avert the severity of their mental ill health by so many decades, because we only wait when the person now is in the working force, where the person is exposed to a lot of stresses. Then we see, the first episode, but we actually missed it in their teenage years, because a condition like schizophrenia, by your teenage years, you'd have had an episode. We know how we have the teenagers with tantrums and sort of behavioral changes around that time. It is likely that if there's a mental ill health and we observe and we can catch it at that point and start managing. Okay.
Yeah.
Just like we manage all other chronic conditions, if they are put on treatment, sometimes it's even just psychotherapy, not the use of psychotropics, the person should be fine.
Yeah, which brings us to the treatment.
So there is something.
And
yes.
Eddie, before the treatment.
Okay.
Yeah.
Yeah. So before the treatment, I just wanted to piggyback on what Thelma said, that if we are able to diagnose anxiety or any of these mental health disorders in early teenage life, it's better for an adult. So
yeah,
I know not even here in America, anxiety may go undiagnosed or untreated in children because of the population we are looking at. What has been your experience in this population? Are they equally affected? And how do we manage that population in general?
Oh, so there's anxiety. We call it anxiety disorders, and we have about 5 or so different types. So we have it in children as well. I'm sure if I give these practical examples, you can relate with it. So, for example, stranger anxiety. So you take your son to school and he has to go and take an exam to get into class 1. And they take him from you. He's supposed to write these exams before strangers, people he has never seen before. So they get stranger anxiety. They either will not speak or write anything at all. That's anxiety there and then. Then we have we have selective mutism. We have kids who don't talk in school, but they are chatterboxes at home. That's a type of anxiety. Okay, that's a type of anxiety. So we do have it here, but we've not been able to come out strong with research. So if we could say, for instance, last year, the prevalence of, say, selective mutism across Ghana, or even just the cosmopolitan cities, Accra and Kumasi, okay, then we are heading somewhere. But the data on that is a bit scanty. Okay, it's a bit scanty. So I think we can do more. When I say we, I say all of us should be mental health advocates. We have levels of expertise, but all of us should be involved. Because if you do have a niece or a nephew who has some form of mental ill health, and because of that, the person has a lot of panic, disorder, for me, it should be of worry to you. And I think there should be a database that we can use to make policies, informed decisions, good ones that can affect all of us, positively. So it's great, but we do have this kind of anxiety in children. We just need to know the numbers, okay? Data is golden. So if we can generate the data, okay? All the units, the schools can provide us with this, okay? It shouldn't be difficult. If we wanted to look at their immunization records, it's so easy. The school asks you, bring your child's immunization record. So we can have something like a mental health record as well. And let's start from the basis. That way we catch them, we save them, we control whatever mental ill health or disorder they might be. Then we know we have saved our future nation builders, rather than wait and we recognize or we get to know decades later, which by then is probably more difficult to manage.
Thank you so much, Edward.
I wanted to add something quick before we go on to the next question. So with children, we have to talk about their parents as well, right? Because a lot of the parents are very protective when it comes to diagnosing them with some sort of, mental related. I know it all comes back to stigmatization, but how are we going to be able to, educate the parents to be able to accept some of the outcomes of evaluating children at that early age?
So for me, like I said, any platform that you get, if you say you're a mental health advocate, any platform you get, but make sure you're churning out, you're giving out the right information, or invite the experts to come and give the talk. Okay, we shy away. I know a personal relative of mine whose son has autism spectrum disorder. The child was not sent to church, was never brought to church. He took the child to a special school against my will or my suggestion, because now the treatment, the way to go is to put these special kids in quote unquote normal schools, because they get to pick up what normal quote unquote normal children exhibit. So you are actually, like the CBT I was telling you, the exposure to what normal quote unquote children do in their classrooms, which with time will ebb, you know. Ebb in this sense is what you see it being exhibited. So maybe ebb is not the right way, but you see the special kids exhibiting some of the traits of the normal kids in the classroom. But like I said, they never brought the boy to church, never. You don't see them going out with him. For me, I don't blame them so much, because it's what society will give them back if they decide to take this child out. But the way to go is not to keep this kind of child indoors. No. We need to work on the stigma reduction strategies. And each cultural setting has the way in which it addresses the stigma. Like I said, mental health is linked to what? Cultural settings. So let's begin to empower whatever platforms you get. Let's begin to empower people, reduce the stigma. HIV/AIDS, when it came, there was so much stigma. Now we even have ambassadors. We have people who are championing what? The stigma reduction for HIV. I don't see why we can't have ambassadors for mental health. For me, the brain, that's my opinion, I stand to be corrected, but the brain to me is the most important organ. It controls every other thing. So if the brain is not well, we should be concerned. I don't think we should rather shy away. Whatever history we have in the past, by lumping everything into the person is mad, or even linking neurological disorders like seizure disorders as mental ill health. Because you would be sad to hear that some people think epilepsy is a mental ill health. It's a neurological disorder, but not a mental ill health. Okay, but such people are shunned. Okay, they are stigmatized. So talk more of someone with mental ill health. We should deepen our strategies to reduce stigma. There are different strategies. I might not be able to talk about them all, but I talked about the contact. Okay, so you get a contact who would be like an ambassador. So the person says, oh, it's okay, even if you have this mental ill health, you can still live normally. I don't know why we don't stigmatize people with chronic conditions. This is also a chronic condition. We know, let me do a little science. It has a lot to do with neurotransmitters firing out of control, or not being in the right amount. Okay, acetylcholine being the major one. So if your blood vessels too are narrowed, and because of that you have high blood pressure, how should yours be different from mine having neurotransmitters either in low amounts or high amounts? So for me, let's take the stigma reduction seriously. And I'm sure a lot of people will come on board once we start.
Great. Thank you so much, Thelma. That was very thorough. I'm just sitting here and nodding because I'm actually just zoned into what you're saying. So I know you did touch on some of the treatment aspect for children, but I wanted you to just dive a little into the management of anxiety in adults. I know it can oftentimes be multifactorial and very complex. So can you touch on some of the treatment approaches that have been used effectively in this condition? And I will tie that to a question from Eric Kwesi Kakari. So he wants to know where we should go to seek help if we recognize these symptoms.
Okay, great. So I'll start with the treatment. Like you said, I've already mentioned some, like the CBT, it's a cognitive behavioral therapy. If, for instance, it's in the line of phobia that usually gets you into the anxiety, then we try and expose you at the right, should I say, amount to the particular phobia you have. Over time, you are likely not to see it as such a big deal of a phobia, and gradually you'll be weaned off that fear. That is one aspect. That's one, it's not pharmacological. It is purely, it's more like some form of psychotherapy. Okay. Sometimes they can do music therapy for some form of anxiety. Okay. So I want to actually mention an artist here, Enya. Enya sings some very beautiful songs that are used in music therapy. Yes, her songs are just Enya. They are not classical music, but they are just slow and soothing. So it's part of some of the cognitive behavioral therapy that can be used. Sometimes it's aromatherapy. You are so stressed, you are anxious, but some wonderful smells in the air, okay, from some plants, it's enough to calm you down, okay? So we call that aromatherapy. So those are some of the non-pharmacological, or should I say psychotherapy, that can be used. Sometimes it's just having your peers talk to you. So it's more like what? Peer counseling. Oh, this is not a big deal. I used to have this phobia, but I'm off it now. I did ABCD, it worked. Okay. It's cool, isn't it? Then we go to the pharmacological, the drugs proper. So they are in various classes, but the ones that feature most are, let me go a bit technical now, SSRIs, okay, or just SRI, selective serotonin reuptake inhibitors. So serotonin is one of the neurotransmitters. It's responsible for your mood. Okay, so we expect that, like I said, a pre-oriented mood state in which you're anticipating something will go wrong. We can play around that mood. Okay, so serotonin, it won't, that neurotransmitter won't stay with you forever. Or those who are predisposed to this anxiety and depression have low levels of it. So we try to increase the amount. So we say selective serotonin reuptake inhibitor. So we prevent serotonin from being taken up. So it increases in an amount within your brain and then tries to put you in a happy mood. Okay. So that is just for SSRI. An example is fluoxetine, what we call Prozac. Okay. That's kind of a known brand in the US. Prozac. Oh, if somebody is depressed, they put a person on Prozac, okay, or having some form of anxiety, they can put you on Prozac. Then we have the benzodiazepine, okay. So a lot of times people think that, oh, diazepam will do the job. We do have some tools that we use, okay. It's clonazepam and then lorazepam. Those are the mainstay if we want to manage any form of anxiety or depression. Okay, so those are the two that are, should I say, major. We talk about first line is the SSRIs. We have some second line would be the benzo. We have some third lines that the response is kind of like okay, like another big one, monoamine oxidase inhibitors. Okay, it's also a type of neurotransmitter that would also inhibit this. It's an enzyme, okay, but those ones are third line. The ones that stick out most, or should I say are golden, is the SSRIs I talked about, and then the benzodiazepines. Those are the ones we use aside the CBT, cognitive behavioral therapy.
Okay, thank you, Thelma. I just wanted Eric's question again. So when should people go to seek help if they recognize that they have all these symptoms?
Very good question. So if you have these symptoms, the general practitioner, the GP, or should I say a medical officer, even some house officers should be able to pick up these symptoms and refer you accordingly. Sometimes we have something called somatoform. The thing can start as mental ill health and show in the rest of your body. Okay, I'll give an example. If, for instance, somebody came with alcohol withdrawal symptoms, it's not really a mental ill health, but we know the brain is largely involved. It's the reason why the person is manifesting those symptoms. So they come with some tremors, and you can see alcohol use disorder on the person's face. So once you have these symptoms, you can actually just walk into a psychiatric hospital. So we say psych hospital. You can walk in, or you can go to your nearest primary health care setup. That's why I say everybody should be involved. Anybody providing health should know what about mental health so that you can pick them up and refer appropriately. For us to catch it in its infantile stage, manage it rather than catch it when it's too late and we are really just doing palliative care for the person. So walk into any health primary health care. So it can be a district hospital, it can be a regional hospital. Just check in. Let them assess you. Like I said, they'll use DSM-5. That might be used by the psychologist and psychiatrist. But if we let everybody know that mental health is as important as the physical, what you see, physical health, we'll know when you are clocking patients. When we are trying to assess patients and come out with a diagnosis, it will be what at the back of a clinician's mind. It will refer as soon as we see that this needs extra attention mentally.
Right. Thank you. Thelma, this is just by the way. I know you mentioned aroma therapy. Does the smell of chicken soup count? Like, just so what?
It could. Yeah, it could. Yes, it could. I mean, somebody could just the smell of a banquine. It's enough to give the person smile. Some not soup, okay, or some pepper soup. So for me, aromatherapy, yes, it does. It's able to calm people's nerves. Someone just needs a pedicure, needs to go out with peers to pedicure and talk out, then the person is fine. The anxiety is off. Yes, so if chicken soup does it for you, chicken soup it is dead. Yes.
All right, thank you for clarifying that. So I'll hand it over to Edward.
Yeah, thank you very much, and I'm really enjoying this. So my next question is, can you die from anxiety if you don't treat it? Right? And
yes,
go ahead.
You could. Mm-hmm. Okay, you want to finish with your line of questioning?
Go ahead, and I'll follow up later.
Okay. So there's actually one, the panic disorder. Okay. For that, it actually gets physical. When I say physical, so we have palpitation. Your heart tends to beat faster than it should, and then you are sort of trying to catch your breath. Okay. If you are not managed, that can become an acute form. You would have to go to the hospital for treatment. I've not seen data that says, oh, this number of people have died from panic attack. But if anything can get you to catch your breath, if you're not able to catch it, then you could die, isn't it? So for panic usually has a physical presentation and it can be dire. So normally we say the moment you see this, please rush. Don't wait. Like how I was waiting for my results. I could have gotten into a panic disorder, okay, where I'll have increased pulse, my heart will be racing, I cannot breathe, I'll be trying to catch my breath. Sometimes there's even abdominal distress. So you have this, you don't know where it comes from, you just suddenly have pain in your abdomen. For me, this can be a medical, emergency. I don't have data that says this number of people died from panic attack, but it could. Okay, so for me, it shouldn't be taken lightly, especially for someone who has several episodes of panic attacks.
Right.
Some few studies have tried to link that to transient ischemic attacks. Okay, the panic attacks to TIAs. Yes, the link is not very strong, but I believe if we dig more, there's more data. It could make this this link stronger.
Great. So who leads me to my next question about how we are going to really make people aware, especially among Ghanaians and sometimes in Africa in general. So we have this perception that, and especially Ghana, when someone has a mental illness, we just put all of them under one umbrella and say, "Adrenana say," right? So basically, we are saying "Ipana abodam," right? And you told me there's actually a big book that has different diagnoses. I'm wondering how we'll be able to communicate that to people back home so that it's not everybody that is saying, right? Some people can be treated, and then even when they are treated and they come home, people say, "Oh, obodamni ayasani already." They'll do you know, those kind of statements get pushed around. You know, it's just like this.
Edward,
This is a yes.
Edward, we need interpretation for that, please.
So what it literally means is that even though a supposedly crazy guy is cured from the hospital, he still has enough to scare little kids with it. You know, it's a statement that we make in Ghana all the time. But how are you able to convince these people to really understand that, hey, people can actually be treated and they can recover from and do well in community, you know?
Okay, so stigma reduction. So yes, the issue of lumping all in one box. I choose to say one straight jacket and say anybody that has a mental ill health is mad, quote unquote. That is very wrong. That is inhumane, and that is against the individual's rights. Okay. What we need to do is to know that it's also a chronic condition. Like I talked about the neurotransmitters. So, like we have HIV/AIDS that affects your blood. Okay, you have a pathogen that's affecting your blood. Now we have neurotransmitters. There are chemicals that are released by our nerve endings, and there's a problem with it. Just like you have problems if you have a cancer, it's in your blood. You could have cancer of any organ in your body, and we say it's chronic. So let us let us separate the different mental ill health and look at them individually. When the person comes back into the society, we should be able to integrate them back into the society. Let's not stigmatize them. Let's not, when it comes to employment, let's not say, oh, this person is quote unquote mentally ill, so will not be able to function. I've told you of celebs, scientists, anybody who is interested can Google it up. We have people who have had bipolar and have done extremely well. People with bipolar they pay attention to detail. People with OCD, they are the best people, they make the best writers or scientists because they'll dot all their I's, cross all their T's. So does it mean if you have any form of mental ill health, you are less functional? No. We just need to manage you such that you have productive activities. You can have fulfilling relationships, and you can adapt to change and adversity. So for me, we should separate it. I even wish to see one day that we would have a psychiatrist who has specialized. I know one who has specialized in drug addiction, So substance use can result in some form of mental ill health or can even give you anxiety. Then we can look at the ones that are purely for anxiety in children, So someone who is like a pediatrician psychiatrist who specializes in just anxiety in children. Then we have, there's one I know, she's a neurodevelopmental psychiatrist. So beautiful. So normally she work with children because those are the ones that are developing and might have some issues. Okay. At that point, then we know we are getting somewhere. We are not lumping everybody into one box. Okay. Then we know there are chronic conditions. You don't just, if I were to manage your hypertension with whatever first line calcium channel blocker, CBBC, and I just do it for a few weeks and I leave you, of course you come back with a complication. So those we see on the streets, they are actually complications that were not managed properly. But if we know it's a chronic condition, we give them care supporters or treatment supporters like we do in other conditions. So they help them through with taking their medication. I don't think we would have some of these complications on the streets. Okay. So let's segregate it. Let's treat them as chronic conditions, manage them well. And I'm sure we would get far and let the policy makers, those who matter, get involved.
Thank you so much, Thelma. You touched on the point that I wanted to follow up on. You mentioned integration and back into the society. How are we doing in that regard? Because I'm thinking if someone was treated, seen to be stable, and they're released back into the society, and they're going back to be facing the same stresses without the support they actually need, there's a high likelihood that they're going to regress. So do we have any reintegration like processes that we put some of these folks through when we mental facilities? Yeah.
So we have this cadre of mental health professionals that we call community mental health officers. They are supposed to, they are the community level. They are supposed to help with reintegration of such members into their society. So they usually will talk to the community members, opinion leaders. Demystify mental ill health. Let them know that, these people can still be functional. They can still be useful to the society. So they should accept them because, if it's a community and you are coming from somewhere, they might not take you as seriously as the opinion leader or the chief or even the assemblyman within the area. So these we call them CMHOs, try to integrate these people who are under management, mental ill health conditions, back into their society. So therefore, on that front, they are doing that to help reduce the stigma. I don't know if you also know of AA, Alcoholic Anonymous. People who have alcohol use disorder or addiction to it, they have their groups that they tend to meet to help each other out. It's still around the peer, sort of counseling or getting support within peers. Okay. Then I think in the West they have something they call a half house. So it's a place that it's not really back into where you were, but it's close. It's a literal meaning of it. So it's a place that whenever you want to seek refuge here is you want to see your kind. Usually you say, people with mental ill health, depending upon the type, are of a kind. So sometimes they want to meet each other, talk about how life is going, how are you coping, still around the peer sort of counseling or encouraging each other. So these ones have been set up. But I know of community mental health officers who try to integrate these people who have been managed back into the society. So the issue of the queer identity.
Right. One last thing. So I get that part, but economic wise, how is that reintegration going? Do we have like specific places where they can send these people if it's basket weaving or some sort of craft that they can engage in to give them some form of income?
So for now, there's no clear-cut plan or clear-cut policy for that. So until of recent, maybe a decade or two ago, when we thought maybe addiction, mental ill health, especially substance abuse, we thought it was a behavioral thing, more of a moral thing, instead of linking. Now we know genes have a role to play. So it's not morality. They should be treated as a medical condition. It's a mental ill health. So it's still taking us some time. I believe we are lagging behind. We should put in policies, whichever administration of the day should put in policies to make room to integrate these people back. Because it becomes a vicious cycle if they don't get integrated back into the society. They will go back to where they were. It will deteriorate. And for me, that is human resource lost. When I say lost, this person cannot engage in any productive activity with their state if they are not managed well, reintegrated, then to earn a living for themselves. Then they become a burden. Okay, not just a burden, they relapse, they go back into the same vicious cycle. We see them on the streets, there are complications. That's how I call them, they are complications. If they are managed well, they won't be on the street. Okay, there should be some form of comprehensive plan. I think we don't see it as, some people say it's an African thing. So as an African, you're not supposed to be depressed, you're not supposed to be anxious. But for me, those are all they are fallacies. Once it is not linked to any race, okay? Mental ill health is not linked to any race, okay? It is genetic, yes. But then what is the racial connotation to it? Such that if you are depressed as a Black person, you can't voice it because Blacks are not supposed to be depressed. For me, that is falsehood. Everybody gets depressed. Everybody gets anxiety. And just like we have chronic conditions, mental ill health also needs to be managed as such.
Right. Thank you, Thelma. And just before we wrap up, quickly, if you can tell us this, explain this to us under 1 minute. So we know in Ghana, most things are cash and carry. So the one with the most money is to have the services. How will people pay for some of these services if they need them? Psych evals, or they need to be admitted in the mental institution, stuff like that. Who is paying for these services?
So government is kind of paying for some of it. So some of the medications are on the national health insurance. Of course, if you have national health insurance, you get to, if you are admitted in the ward, you get to be managed for a number of days, okay? So you'll be fed by the government, but it's for a number of days. And what people forget is, people with mental ill health also present with other medical conditions. So I could have maybe schizophrenia and have diabetes. So my diabetes should be managed. I could have hypertension. It should still be managed. Okay. So their drugs are largely free. When I say largely free, it is supposed to be free. It is not always free, but it should be free, if you ask me. And it's covered by the National Health Insurance. So it should be free, but it's not always the case. Okay. I don't want to dive into that because there are a lot of other administrative issues. For the fancy treatments like the aroma therapy or music therapy and the rest, I don't think it takes so much to implement it. Our psych hospitals should be able to do it. Sometimes you don't have to always wait on the government per se. If you can get a rich few to start. Not everybody is on the same level economically, but if a rich few can help you set it up, then the ones that are not so rich can also benefit from it. And maybe we could recognize the rich few who have started it and sort of demystify the whole mental ill health. Okay, we were all here when we learned the Archbishop Duncan Williams' son. I stand to be corrected, but he probably has some mental ill health. Okay, he's a pastor's son, but it tells you that anybody can have some form of mental ill health. Okay, sometimes you see celebrities, like I was talking about the PJs, doing certain things online. It's not for PR or anything. Some of these people, we need to further look at them, or they need to seek help. Sometimes they cannot be the ones seeking help. The people around them should help them to seek help and then be properly assessed and diagnosed.
Okay.
So
and
for
Thelma,
me, yes.
I'm sorry to interrupt you. So we have a question from Mr. Mensah, who is my dad. He wants to know why some people who have symptoms of mental health issues, some tend to be aggressive, whilst others remain calm. What could be the cause of this difference?
Okay, so there are episodes. Okay, so and I would choose to use the words aggressive. I think they are presenting an episode. Okay, so either they are having some form of delusions, or they are hearing some voices. Okay, hallucination can be visual or auditory. So sometimes you are seeing things that are not there. So if, for instance, I'm seeing something that looks like it's coming to hurt me, I will want to protect myself, isn't it? But you cannot see that. I am the only one seeing it. So if my visual hallucination is making me sort of protect myself or be on the defensive, then you will see me as what? Aggressive. But it's my hallucination that is making me do so. I think any of us could find ourselves in that situation. So it's, for me, aggressive. So they are presenting an episode. So usually it's a visual hallucination. They are seeing things that are not really there. Okay, I'll give an example. If someone has alcohol use disorder, they tend to see all sorts of creatures. Okay, so they can say they saw a spider with 16 legs. Okay, so the 16 legs was moving all over the wall. So that's a visual hallucination. If I think it's coming close to me, I want to fight it off. So I will look like I'm being aggressive. But in actual fact, it's my state. Okay. So I think we should try and understand the condition that they are in. Okay. So that's why some of them appear to be aggressive. But really it is the condition.
Condition. Oh, thank you so much. We could go on, but we need to wrap up the show. So take it over.
All right. Thank you very much for all that insightful conversation we've had about anxiety. And as we wrap up the show, I'd like for you to give our listeners some few words, some few advice about mental health before we wrap up the show.
All right. For me, I think you are not complete health-wise if mentally you are not healthy. Okay. Like I said earlier, the brain, it's the master of your whole body. So if the master is not well, it tends to affect other parts of the body. Mental health should not be seen as how it was portrayed several, maybe even a century ago. We should look beyond that. The idea of an asylum, because we think mentally ill individuals are violent or aggressive. For me, it's neither here nor there. We actually have some level of depression that is going on with people that have chronic conditions like DM, diabetes mellitus, hypertension. And depression, like you know, it's a form of mental ill health. So let us look beyond how mental health has been portrayed over decades. It is just like any chronic condition. Anybody could suffer from it. Let us begin to see it at the basic healthcare delivery level. Clinicians should look out for signs of it, pick it up early, refer to the right clinician, expertise, specialist to manage. Then what we can do, lay people, let's not stigmatize.
Right.
Because it doesn't take one person to stigmatize. It takes a whole community. But it can take one person to reduce the stigma. You know, we have colossus within communities. We have those who pull crowds. We have leaders. You know, they are not necessarily the highly educated, but they are the grassroots people. That they can pull people together, they can organize people. Can we get these people to be part of the stigma reduction? Okay. Like Epia Dente. I mean, I mistakenly watched the video and I had anxiety, had generalized anxiety disorder. I couldn't sleep because the images kept replaying. Okay, so that woman most likely had Alzheimer's. Okay, 85 and upwards. That woman was 90. It's most likely she had Alzheimer's, some form of dementia. So they will normally say things that don't mean anything. Okay, you wouldn't be happy if that was your grandmother or your great grandmother, but because we don't understand, and culturally she had been put there, quote unquote, as a witch, so it's sort of tied in with whatever she said. But for me, it was what could have been pure dementia. That woman is too old to have killed anybody. It's not impossible. But for whoever, the person who threw the stone, to have the effrontery to do that means there's some cultural barriers that we have to break. That's why I say mental health cannot be divorced from what? The cultural setting. They must be married. It must go hand in hand. And where we need to stigmatize the portion of the culture that we need to take away, it won't be done in a day. But if we don't engage the stakeholders, those who matter, we won't get anywhere. The last thing I want to say, if you think you have symptoms, please don't pop the pill yet. You might be popping the wrong pill for the presumed mental ill health. So seek help if you think you have anxiety. And with COVID, anxiety is rife.
All right. Thank you so much, Thelma. I'm sure our audience and our listeners really enjoyed this discussion. I, for one, learned a lot from just listening to you talk. So again, thank you to everyone for sharing your afternoons and your evenings with us. We just wanted to let our audience know that the HealthInfoAfrica Show will be taking a 2-week break. So we'll keep you guys posted on when we'll be back on air, and we'll post that information on our Facebook page. And for those of you on Instagram, also you can find that same communication on our Instagram page. So again, thank you guys so much for always coming along with us, and we'll see you when we come back. Edward, do you have anything to add before we wrap up? I think I need some aroma therapy myself.
You do.
Yeah. I mean, we learned a lot today, and we thank Thelma for bringing us all those insightful discussion about anxiety. And again, as we go along, we will learn more about mental health and how important it is. So thank you very much for listening, everyone. And thank you for coming, Thelma.
Thank you.
Thank you for having me.
It is the senior most community pharmacist, Dr. Tuli.
Tompo Asembeng.
Oh, no lie. Then I say if your driver can't pick you, I make you people give me lift go. Shark is inside now. I'm at say it's on link copy. But
Tompo, 11 p.m.
Oh, if it comes a seed in the who give me. I guess some entanglement before that side.
You know they hear social distancing, eh?
To lepe fam D, sem crowd, the whole. As I be young in the Emmas are they cool. If you no go pick me to catch him and small left.
See, this be the problem. Who tell you say corona dey affect youngins? If you know they care about your life, if a guy say NSL be over 50 years, away get hypertension, we poppy to be diabetic. Charlie them their go mess them up.
You are go wear face shield.
And that changes anything? That thing they protect only your eyes.
Plus face mask.
Charlie, the youth will they take this thing for granted. It may not kill you, but if it give you long-term damage to vital organs like your lungs, if you go get for outside cargo house, they give your OGs where them die, will you be able to fend for yourself?
Chama, so I can't say more. Because unless I start, they do Yahoo, I enter Benino, na phone cost me this the COVID said make it left one at top. Who?
If people know they follow simple directions like social distancing, hand washing, wearing face mask and things, the COVID don't go anywhere. And the way they make careless there, it be like you know go left with anytime soon.
So to lazy my shadow make beans in.
If you love yourself and the people around you, they house and take your shadow go back cry.
You are here, you more like dog me. So they kill my vibe cry.
But we forget responsibility and keep fighting with positivity.